Okay, at this time, I have everything set up. Only took a few minutes to gather all my stuff. Got the PowerPoint up over here. This is the view from the back. The students will be right there at the white tables. We will have 3 to 5, depending on calls, as it depends with that. As you can see, there's a podium up there with the PowerPoint going to be displayed at that screen. I've got the mouse and also the projector remote as well. I've got my paperwork all ready for as soon as they get in here. Again, there will be seats right there. I've also went ahead and got the 2 stations and all the equipment necessary. So we have our PPE, we've got our mannequin that will be used in both of situations. We've got our rescue breathing device there, the BVM, our AED. We've got our oxygen delivery devices, the non-rebreather, the oxygen tank, regulator, and the key. Also, we have spare bottles as well. And then also, if necessary, we have extra AEDs and mannequins also there. Oh, yep, you guys are good to come in.
All right, thank you, Mr. Brey.
All right, take a seat right here.
Okay.
We'll go over some basic stuff. Good morning.
Morning, Cap.
Morning. Alrighty. So, first things first, my name is Mike Brey. I am a firefighter paramedic over at West County EMS and Fire. I am going to go ahead and teach you guys chapter 23 of the Essentials of Firefighting book. We're going to go ahead and get started with that. So chapter 23 is going to be provider first aid. We're also going to have 2 skill assessments with that. Okay, I'll go over that here in a minute. But to start things off, just want to let you guys know, happy to have you guys here and appreciate you guys taking this class. If you guys need anything, the 2 exits are there and there, and bathrooms are out this door to the left, and men's is on the right, women's is on the left. Hopefully it is a good temperature in here. If you guys have any complaints or wanted to adjust it, just let me know. We can get that situated, okay? We're gonna hopefully do a break around 15 to 20 minutes, then come back, give maybe a 5-minute break, just stretch our legs, stuff like that. Gonna keep rolling through the lecture. So we do have a slideshow to show you. Also, we will then break around. I have these skill assessments for you. So I'm gonna hand these out first, okay? That way on your breaks, you can go ahead and look them over. We will be testing on this. This will be a section that we will test for your skill practical, okay? So, like I said, go ahead and look at these whenever you guys get a chance on your breaks, and we'll go with that, okay? Before we get started, is there any questions?
Will lunch be provided?
Lunch will not be provided today. It's going to be about 2 to 3 hours, hopefully, if not longer, but no more than 4 hours. So we're going to get that done, okay? I apologize for the delay and getting that call. I appreciate you guys all getting back and getting seated so we can continue this lecture. So we're going to go ahead and get started on this slideshow. We've already went through basically everything necessary in order to get this class started. As a reminder, we got our exits both here and here. Bathroom is out that door to the left. Again, if you have need any reminders for that. We're gonna go ahead though and get started on this PowerPoint. So this PowerPoint is about 150 slides. We're gonna go ahead and try to get out as much as we can. We might take breaks every about 20 to 30 minutes. I know I said about 15 to 20. We're gonna try to push it a little bit longer. So if we can do that, that would be great. Alrighty. So the first learning objective in this slideshow is going to be to describe the role of the fire service in providing emergency medical care. So as you can imagine, in the basic provider level of this course, I know we are all firefighter paramedics, but you got to imagine in the world that we live in today, there's not always those situations at firehouses. So, or just EMS agencies as well. So we're gonna go ahead and we're gonna kick it back to where we first began our careers. with that being said, we're going to go ahead and just kind of base this off of that, okay? So EMS, what is EMS, right? EMS is the treatment on the scene and then the transport of victims to a healthcare facility. We like to call them patients, but in this slideshow it will call them victims. But that is basically what it is considered to be EMS, emergency medical specialist right there. So we're going to go ahead and move on to what the ambulance services come down to. So you've got multiple different ones. You have about 3 different styles. You've got your hospital-based ambulances, you've got your fire-based ambulances, and then you have your third service ambulances. Those are those private ambulances we see around here, Abbott, Gateway, or Medic One. So those are all of those. You know, your hospital-based one is Mercy, how they have their transport team, and then obviously fire-based ones, a lot of us. So ambulance services, they like to put it in here, become familiar with equipment, protocol, standards of care. It's also good to regularly train EMS stuff as well, especially in terms of for fire departments that have ambulances. It's a little bit different than if we were just a fire department training alongside with our EMS agencies, so that way we have a good relationship with them and we can coincide together on calls to give the patients the best level of care that we can. So again, the personnel with limited EMS trainings, fully functioning paramedics, they're in 2 different styles, or 2 different sides of the spectrum. You know, sometimes you might have people that are a little bit more educated than others when it comes to the emergency services. Some will literally call themselves ambulance drivers versus a paramedic that is going to do everything they can to save a life. So with that being said, the review question that we're going to go over is just, or that I want you guys to think about is, what role does the fire department play in providing emergency medical care? Based off of those slides, you should be able to answer that. So I want you guys to take a second, just think about it over those last few slides and think about in terms of how we can define that. I'll give you guys a second. All right, to move on. Again, this is very similar to that last question, so we're going to go ahead and just kind of skip through it because it is very similar to how I just worded that for us. Learning objective 2, is going to be explain patient confidentiality requirements. So again, throughout these next few slides, I want you guys to think about it as we're discussing it. So the biggest thing when thinking about confidentiality in terms of what we do, the biggest one that we come to think of is HIPAA. So HIPAA is defined as the law that regulates use, distribution, and storage of protected medical information, or also known as PMI. Again, HIPAA is also Health Insurance Portability and Accountability Act. So that is going to be anything, as you can see on the board, it's anything that's going to be part of any records of any sort with any patient. So we cannot disclose anything with anybody unless they are a minor and we're discussing it with their parents or anything along those lines. We got to make sure that we're really being our patient advocate when it comes down to these issues with HIPAA, just because we don't want the wrong information getting in the wrong hands. So just kind of really internalizing what the situation is and who information can be shared with. So again, that PMI, that protected medical information, just make sure that you're keeping that in the back of your mind of what information would you want shared with a random person, or even in terms of if you're not on good standings with somebody, would you want them knowing some of the information that you're about to share? So these are just some different things to keep in mind when talking about this medical information. So as I was just saying, when it comes to who and what we can share information with and what it is, that is this question I want you guys to then think about, is just on calls that you can think of in your past, what are things that, or situations where you've been kind of in a sticky situation when it comes down to what you can share and who you can share it with. So again, take a few seconds to think about that, okay? Alrighty. So as most of you guys can kind of put it back to, is a lot of the times we see a lot of neighbors that come outside, and neighbors, they like to be nosy. So when it comes down to neighbors asking about, is Mrs. Smith all right, or what's wrong, or is she going to the hospital? I'm sorry, ma'am, I cannot share that information with you. Because why? Because she's not a relative, she's not a family member that is going to be basically eligible to get this information from or to. Now, again, with that being said though, you want to make sure that if Mrs. Smith is in the back of the ambulance, ask her, say, hey, just so you know, your neighbor is here. Do you want her to know what's going on? And if she gives you consent, then yes, you can go ahead and give her that information. But if not, always use that privacy thing and have the respect to ask first. All right, so moving on to learning objective 3. That's going to be identify communicable diseases that first responders commonly encounter. As you can imagine, the world is not the cleanest place. Especially as an emergency medical professional, we tend to run into patients that have anything you can think of. Sometimes in your career you might see some things only once or twice. Sometimes you might see others, hundreds of times. But the main thing is that we need to make sure that we're taking the correct precautions, the different PPE necessary to make sure that we are keeping ourselves safe in these situations. So with that being said, infection control, the biggest thing, breaking things back to EMT school, what was the first thing you learned? Scene safe BSI. Making sure you have all of your BSI, your body substance isolation procedures done. You want to make sure that those gloves are on. If the situation comes where you need to have, eye protection, masks, head protection for anything along those lines, gowns, face masks, complete shields, anything you can think of that's going to be necessary to keep yourself safe. Especially when it comes down to different aspects of injuries when it comes to needle sticks and everything. Those are going to be a little bit different in terms of that BSI portion. But we also want to make sure that the main thing here to take away from is that patients may have communicable diseases which are not always obvious. People aren't necessarily just going to tell you, I am HIV positive or I have Hep B. Those things are not just usually talked about. Those are some things that maybe in the hospital you get there and you tell them like, yeah, this is the situation, and then they say, oh yeah, did they tell you they have HIV? Because that's something that we as medical professionals need to know in order to stay safe in our own lives. So those little things are something that we want to make sure that we are disclosing with our patients as well. Also, along with this slide, those immunizations, those are something that we want to make sure that we're taking care of ourselves. Getting vaccines from all the different diseases that we needed to as children, and then into our adulthood lives. We want to make sure that we're staying up on shots and immunizations, so that way we protect ourselves from these situations. Because even though it might not happen, we want to make sure that we're going to isolate every single situation to give there to be no reason to potentially get this stuff. Hepatitis, that's going to be the one that we want to make sure that we're protecting ourselves from most when it comes to these needle sticks. Even though it is a very, very low likelihood of getting this, even from a needle stick, from a positive patient, we want to make sure that we are still taking those precautions of not getting it in general. So this is the inflammation of the liver, obviously with hepatitis. And so viral hepatitis is the most common, as we've learned through paramedic school. These can also be caused by drugs, alcohol, hazardous chemicals, and it could also be hereditary. It could be passed down from mother to child. But as we kind of see, usually hepatitis is going to be in those homeless populations that share needles and everything like that, which we obviously around here do not have that much of a problem with. But you know, people that have worked in the city or anything like that can obviously attest to the fact that there is that situation that could happen. So Hep A, this is the typical one that is caused by consuming contaminated foods or water. Can be transmitted by close contact with infected individuals. Obviously, the signs and symptoms is going to be the fatigue, abdominal pain, fever, dark urine, yellowing of eyes, and skin color, the jaundice that we see. It is also the least serious form. That's why it is usually type A, to start with that. Then there's usually no long-term effects. That's why, but it is something that we also want to stay, ideally not wanting to get. The next one is Hep B. This one is that one that's through the bodily fluids. It can be short or long term. There are those vaccines for it, and there is treatment for it as well. It also can cause serious liver damage and scarring of the liver. The signs are pretty much the exact same as Hep A, which is why whenever we are getting tested, or if we think we have an exposure, we want to get tested as soon as possible so we can take the prophylactic steps in order to get these things taken care of. And like I said, if you don't get this taken care of, it could be lifelong infection that could be serious. So this next one, Hep C, that's a pretty bad one right there. Typically they're transmitted through bodily fluids as well. Individuals can go for many years without even having symptoms. It's kind of like HIV, where sometimes the key is just unlocked, and then that's when you know you have it. So again, any situation where you think it's possible that you could have been exposed to Hep C, you need to make sure that you're taking the correct procedural steps in order to get checked. Okay. This one is big on the liver damage. It could be long-term or permanent in general. So, but other than that, liver failure is usually typical and can occur on that. Hep D, that's the uncommon strain. It occurs in individuals affected by Hep B and makes the effects of Hep B even worse. So that's the one that obviously is going to be kind of the only thing that is going to basically happen with that is if you know that you have Hep B in general. We're going to give it a few more minutes, take a few more slides, and then get switched on over. So again, there are those vaccines that we want to make sure that we're staying aware of. Make sure that we have that Hep A and Hep B vaccines. And they say that they don't have any vaccines currently for Hep C, but we want to make sure that as soon as that stuff is, we want to make sure that we're staying on top of that if it does come out. Firefighters need to be immunized against hepatitis and other infectious diseases, as said, just to make sure that is one of our BSI precautions by staying vigilant with that. Another one, just wash your hands. That's a big thing. Wash your hands, super easy. There's no reason why we shouldn't be able to do that. TB, that's another one that's very common in the homeless population due to the spread of needles that are obviously reused. It is a bacterial infection that's usually spread through the respiratory system, coughing, sneezing, anything along those lines. It is airborne in nature. The biggest thing on this one is the signs and symptoms. So TB is not always active. Once you have a flare-up, that is when those signs and symptoms start occurring, and that is when you have the likelihood of getting it. But in general, if someone says that they have been exposed to TB, they've had flare-ups in the past, they might not be showing signs and symptoms now, but go ahead and take every precaution. Make sure those masks are on them and yourself, and just make sure we're taking those precautions in general without even, so we know for a fact that nothing's going to possibly happen with us in that situation. Those signs and symptoms: fever, fatigue, chills, weight loss, painful breathing, and a productive cough that lasts more or several weeks. The biggest things that we're going to see is that fever, fatigue, and chills, which is also seen a lot in the flu. So, anybody along those lines, we want to make sure that we are staying on top of our BSI precautions. So, like I said, with this, make sure that the N95 is going to be the best when it comes down to our BSI precautions, along with those gloves, because since it is airborne, put an N95 on them, put an N95 on yourselves. That way we are taking away all of the possibilities of it getting infected to us. The skin test is not the only test at this time now. They are able to test TB through blood work as well. So that is something that we want to make sure that we're staying on top of annually when it comes to being in this field. Just because, like I said, there are situations where patients, might have the TB not active, but at the same time it could be active and they just don't know it, and it can have the chance of spreading it also. Other than that, there is no vaccine typically for this, so we just got to make sure that we're staying on top of the BSI precautions. HIV and AIDS. So obviously HIV is the precursor to AIDS, so not all people know that they have HIV either. That is also something that they can live most of their life with without knowing that they're actually infected until it finally does start affecting their organs. But again, we're going to go over the fact of HIV and AIDS as a whole. So some of those main ones is it does weaken your immune system to the point where your body is unable to fight off diseases. So that's why these people typically show a lot more signs of severe sickness when it comes to even the basic common cold, just because of the fact that their body's not able to fight off those any infections or anything like that. So other than that, if the people do have HIV, those are also going to be the people that are typically going to possibly have the infection of TB as well as hepatitis. It is only spread through contact with infected blood or bodily fluids. So it can be sexually transmitted as well as just through needle sticks and stuff like that as well. So that is why it's again going to be something that we're going to want to know as we're starting IVs or anything like that. Just almost treat everybody like they have infections that you do not want. Stay on top of your precautions, no needle sticks, and just make sure that we're disposing of those needles in a correct manner right away. And then the last thing with the BSI, not only do you want to stay on top of those precautions as we're treating the patient, but afterwards as well. Make sure that the blood, if there is any that gets on the ground or on the seat, make sure that stuff is wiped up with bleach or anything that's going to be able to kill these viral infections. And it should say that on the cleaning supplies as well, whether they do have these viral cleaning capabilities or not. So one thing to be aware of is that medical equipment and services should be decontaminated immediately following soiling to prevent the spread of infectious diseases to responders and other patients. So that just goes into what I just said of making sure that you're using the correct cleaning supplies for the correct mess, okay? Especially viral diseases in particular. So another big one is the multi-drug resistant organisms, the MDROs. Very difficult to treat and to stay away from, just because it is multi-drug resistant. So this is your MRSAs. That's the staph infections. Those can cause a lot of problems, and they're easily spread. So we want to make sure that if that is in a sense of a possibility for us in the ambulance or anything like that, just make sure that we're staying aware. Make sure we're getting the correct history from these patients. That should almost be a question that we ask. I know in the hospital they do that as well for everybody if they've ever been diagnosed with staph or MRSA, VRE, anything like that. Just because of how easily spread they are and the way that we can get them to. So So some other things that we gotta be aware of is that H1N1 influenza. That's the swine flu, avian flu, bird flu. That's obviously has come into our history and caused an epidemic for us in the past. We want to make sure that we're being prepared to treat these patients. Again, not only do you want your mask on, you want the mask on them as well. So that way we can completely eliminate that possibility. And then there's just the sanitizing. Make sure we're cleaning afterwards, hands, and then the rest of the surfaces that could have been touched or affected. As I was saying before, if you think that you've been in contact at all, make sure we're following those protocols in general when it comes to getting treatment or getting tested for treatment or prophylactic treatments with that as well. So a little review, what are 3 common diseases that first responders, what are 3 communicable diseases that first responders commonly encounter? Go ahead and take a few minutes. We're gonna go ahead and get that finished up, and then we're gonna get a break before this next section. Alrighty, now let's go ahead and take 5. Come back, get back to your seats, and we're gonna get started up on the next sections, okay? Alrighty, now that everyone's back, let's go ahead and get started on the next few sections, okay? So learning objective 4, this is gonna be explain ways to prevent the spread of communicable diseases during a medical emergency. Or excuse me, during emergency medical care. So to piggyback on the last section, we were talking about these communicable diseases. We're gonna now go ahead and talk about the immunizations and the preventative issues or the preventative steps that we can take to keep ourselves safe when it comes to providing, care for these patients, as well as keeping ourselves safe from the possibility of getting these infections. So these immunizations that have a possibility of getting stuff, you may be required to immunize against Hep B, MMR, chickenpox, tetanus, and influenza. Those are typically the ones that we're going to want to get vaccinations for. And MMR, chickenpox, Hep B, those are usually the ones that you're going to get as a child anyways. So we should just be able to move on and make sure we keep ourselves with that influenza shot. Typically spring, fall, if fall, anything. But you want to make sure that we're staying up to date on those flu shots as well. The next one is the tetanus. That one, they recommend at least every 10 years, but if it comes down to it and you have something that happens at year 5, they're going to make sure that you're going to get that tetanus shot as well. Just because it's easier to give that tetanus shot than it is to treat tetanus once you finally get it, because that is not something we want. BSI. So, BSI, pretty self-explanatory when it comes to us. Obviously, gloves, mask, eye protection, head protection. We're gonna make sure that we put that face shield on if we need to, the full gown, and we're just gonna make sure that we take every precaution that's necessary for each situation. You don't have to have everything on for every call. Use your common sense when it comes down to it. We've all been paramedics for some years now. We all know what we can do or what we need to do. But in general, the biggest thing right here, bloodborne pathogens are the most common, but airborne ones are the most threatening. So that's why, if someone's got a cough, put a mask on them, put a mask on yourself. Keep it nice and simple. When those exposures occur, obviously, we're going to want to make sure that we submit our documentation that's necessary for that, as well as following up at the hospital of the transporting patient, because that way they can make sure that they test for any diseases that this patient might have. And if there is no diseases that are coming back, then it's pretty likely that we're not going to get anything coming out of that. But say that they do end up testing positive for something, we're going to make sure that we take the right steps moving forward to isolate that injury. But this is, again, anytime that an open wound, cut, or sore is exposed, as well as your eyes, nose, and mouth. So any opening of your body, and then just any breaks in the skin that goes with the open wounds, cuts, and sores. Sorry. Hand washing almost before and after gloves. That's gonna be a big thing, just because obviously the ambulance is not the cleanest. Houses are not the cleanest. We just want to make sure that we're always using gloves no matter where we're at. Another one that goes along with this is that proper disposal and or cleaning of soiled items. Depending on what the item is, we want to make sure that we are disposing them correctly. So something that is saturated in blood, we want to make sure that we get that in the biohazard bag and put it or dispose of it as requested in that terms. Anything along those lines, though, we want to make sure we're disposing it correctly. We want to make sure that we're not spreading, even bugs or anything like that. Obviously, we run into bed bugs. We want to make sure that we're bagging that stuff up and disposing it correctly. Hand washing, there's no reason to beat a dead horse. Wash your hands. There's, the techniques. If you, for those of you that have kids, you see them on all the bathrooms. Sing happy birthday 3 times, stuff like that. Whatever you need to do in order to wash your hands correctly, you can go ahead and do that. But make sure we're getting every single area that we can. Sometimes that even means moving up into the arms. We've all worked on patients that just were not clean. And, whether that's changing your clothes afterwards, but hand washing is going to be the most important thing when it comes to eliminating the possibility of being infected with anything. So again, make sure that you're washing the wrists, forearms, scrub the pads, wash for at least 30 seconds, and then using the alcohol-based cleaning solution should be only used when hand washing is not feasible at this time. So the reason behind that is the more we use these alcohol-based cleaning things for our hands, the hand sanitizers, is because they don't kill everything. It'll even say it on there, say 99.9% or 99%. There's still that little bit that can create these super bugs, these bugs that are resistant to any of that because you're constantly just making them stronger. So that's why hand washing, that's your number one thing that you want to go to. Avoid the alcohol if you can. Just use the hand washing with soap and water. So PPE, again, we use PPE in our lives every day when it comes to the fire world, when it comes to EMS. It's just, even if you think about getting ready in the morning, what do you put on? Your PPE is technically your clothes. You want to stay from the exposures and stuff like that. When you're going out in the cold, you got a long sleeve shirt on, some pants, maybe a hat, everything along those lines. That's still PPE when it comes down to things. So again, just make sure that it is based off of the concerns for the call and the patient in general. So we want to adjust our PPE level depending on what is occurring at the time. Gloves obviously should be worn on every single patient. 1 pair of glove per patient. You don't want to go from one patient to the next and constantly spreading everything there in those MCI events, because not only are we trying to protect them from ourselves, we don't want to give every single person, person A's diseases. That's just not being a patient advocate. So we want to make sure that these gloves are being changed for every patient contact, as well as using typically the non-latex gloves are kind of our mainstream nowadays, because there's so many latex allergies out there that pretty much everybody has eliminated that latex glove. We're just going to the non-latex. Again, remove the gloves and put a clean pair on before going to the next patient. So if you know that this situation, again, is going to involve multiple people, carry extra gloves in your pocket. There's no reason you can't do that. And then say, person A, you're only working on one person, but your gloves get just drenched in blood. Do you want to go touching everything? No. Take those gloves off, put some new ones on, okay? Gloves are going to be our number one friend here. So when removing them, you just want to make sure you're not obviously grabbing with your bare hand. You want to make sure you're sliding those 2 fingers in there and getting it off that way, getting the second ones in there as well. So that way we are isolating completely from it. We're not just using gloves for no reason. We're using it for a cause, and we're going to make sure that we get the wanting effect on that. Again, disposing it, if it is saturated with something, make sure it's going in the correct disposed trash can or biohazard bag, anything along those lines. Eye protection. So again, that's going to be in those situations where you think that somebody is like coughing completely or coughing just direct anywhere, and you see some nasty stuff coming out of their mouths. You don't want that in your eyes or your mouth, something like that. So go ahead and put that eye protection on if you need to. If you wear glasses, Dan, great. That's perfect, because now you don't have to worry about having to wear extra eye protection. But in the sense of, say you're giving birth and or you're delivering a baby, you might want to put some extra glasses on there to cover everything and not just that thin line that is covering your eyeballs, just because it can get on your eyebrows and drip down. When you're going to be using true safety glasses, you're going to have those covering the entire eye, where there's going to be no issues with that. So again, there's safety glasses for a reason. Utilize them in those situations that's needed. And actually, for those that have those glasses, they do make those specific ones that are very thick, that kind of go over that, so that way you can use your prescription glasses and actually use safety glasses as well. Along with that, the glasses, I also mentioned the face shield. These are going to be those situations where you're going to cover up everything. These things, you don't know what's going to happen in these situations. Giving birth, you don't know what's going to spray at you or anything like that. Or even the situations where you have a combative patient that tends to spit or anything like that. Safety glasses and just wearing a mask, you still have all this other stuff, all the other part of your face that's going to be exposed. So go ahead and don one of these if necessary. It keeps everybody safe. You can still see completely, because all it is that plastic shield. So also, it brings up the point that a helmet shields and Bork eye shields do not provide suitable protection for emergency medical use, because they are on fire helmets. So they're not really considered emergency medical safety. Sorry for the confusion of words. They're not considered for emergency medical use. They're just served as fire protection use. So again, with the masks, there's plenty of different kind of masks out there. We have just a straight up, fabric mask that we have that just kind of keeps us from things getting into our mouths. That's all. It's not very protective when it comes to viral infections or bacterial infections, anything like that. Things can still get through it, which is then why you can move up to the N95, which will be on the next few slides. We're going to talk about that. But in terms of just the basis of the mask, that's something that we're going to want to just do just to make sure that there's nothing that's going to directly get in contact with our skin. So if it's something where someone's just coughing, there's stuff kind of coming out, we just want to make sure that we're keeping our mouths completely clear of all that. So again, best to use the mask that provides greater protection, placing the mask on the patient as well, so that way we are completely closing that loop. It's not just me that's safe, that we're eliminating that person from even being able to spread it in the first place. So that's going to be our main spot. Here it is. Here's the N95s. The reason why it's called an N95 is because it blocks out 95% of airborne particles. So those are those viral infections, anything like that, which is going to be one of the main ones that we want to use for people that are infected with TB. So again, putting a N95 on the patient as well as ourselves, that's going to give ourselves the most protection when it comes to those more serious infections that are caused from airborne pathogens. Also, the biggest thing with these N95s is they should already be fit tested on you. You should know that you're a medium, or if you're a large, Dave, if you're a small, stuff like that. We're going to want to make sure that we're paying attention to staying on that size. Say you've gained a little bit of weight over the years and you start getting that bigger neck or that chin, you want to make sure that you're getting tested again just in case you didn't go up a size. Or if you've lost weight, you want to make sure that you're not shrinking and that chin line has gotten smaller, because we need that correct seal. Again, that is why us as firefighters, we need to stay clean shaven, because if we're not, that N95 is going to have all that air able to be creased through. So we're going to make sure that that's not going to be capable for us. Gowns, these are going to be the biggest things to keep our whole body unexposed from these particles in general, usually bodily fluids or anything like that. Traumas and emergency childbirths are usually going to be the typical ones that you're going to want this for. You don't really care about this for starting an IV or anything like that, unless, you know, you tend to be a messy IV starter, you know, Kyle. But just know where they're stored, know where to get to them quick. Especially in, you know, those emergency childbirths, things are chaotic. You're going to be running around. You're going to be wanting to make sure that you have everything in a correct spot. Sometimes keeping those in a spot that's going to be right by the trauma, right by the childbirth section is going to be key for you, okay? Something that, you know, obviously we don't have a problem with here at the firehouse is keeping spare uniforms. But when it does come down to it, say we're going to a different, you know, firehouse for the day, something like that, make sure you're not just bringing one pair of clothing. We want to make sure we're bringing extra pants, extra shirts, stuff like that. Just in those situations of, you know, you're starting IV, blood gets on your pants, you want to make sure you're going straight to changing that, and also taking a shower, washing your clothes just right away. We're not wanting to let that sit in there, you know, possibly absorb into our skin, everything like that. We want to make sure we're taking those precautions, even when it comes down to situations of, you know, flu, COVID, anything like that. We don't want that on our skin, so we don't want it on our clothes as well. That virus can, you know, linger, stuff like that. Go ahead and take a shower, clean your clothes. That way we have an extra set of clothing to put on afterwards. The biggest thing, again, with that cleaning and disposal of contaminated items, we want to make sure that we are wearing our PPE for this as well. Because technically things are still exposed, these items are still exposed to whatever issue that we're having. You know, whether it's blood, we want to make sure we're still having gloves on. And since we're going to be spraying stuff that has these fumes in it, we want to make sure we're putting a mask on so that way we're not breathing that in as well. But if you need to, make sure you at least have the gloves on. Make sure that we're staying nice and far apart from it when we're getting it sprayed down. And if necessary, when you're transported to a hospital, they all have those decontamination rooms for a reason. Is if something's extra soiled, or, you know, something needs a good wash down, they have those big showers in there that you can just utilize with that for these equipment. So big things are bleach and water. Those are going to be your ones that you want to make sure that the manufacturers allow that. So if it's something like a backboard, yes, it's a great thing to do it on because there's no issues with bleach on that. But if it's something that has, you know, fabric to it or anything like that, make sure that bleach is allowed on it. We don't want to ruin our equipment by putting too much bleach or cleaning it too much with that unacceptable cleaning supplies. Again, if we need eyewear, masks, stuff like that, because these splash resistant, or the splash potential for when we're cleaning, make sure we're taking those precautions. This picture here has, you know, a fire uniform on, so he's got his bunker gear. Obviously, if we're running a fire, we're going to put that stuff in the extractor right away because we don't want those carcinogens everywhere. Obviously, this is more emergency medicine, so we're not going to be wearing our fire gear everywhere. So we don't really have that much of a problem in terms of this. But in general, when it comes down to wearing contaminated clothing, everything like that, if we need to, take your boots off right when you get out of the truck and walk around barefoot until you get some Lysol, get them sprayed down, wash them down, anything like that. Also, you just don't want to be tracking it through the entire house. You know, I know personally when I go home, if I especially have a long day of, you know, our last call was dirty or something like that, I don't, especially my shoes, I don't track those in the house. Just because we run in some nasty houses nowadays. You know, people have very dirty living quarters, and we don't want to bring that dirtiness into our own living quarters. So just make sure you're staying aware of where you're putting your dirty uniforms and stuff like that. I don't want to take my dirty, contaminated clothing and just put it on my floor or in my hamper, exposed to everything else. That's something I want to take off almost in the laundry room, get it in the laundry right away. So again, when it comes down to disposing of the correct contaminants right away, is biggest things is those needles, blades, anything sharp, stuff like that. Put that in the correct container right away. I know there's stories back in the days where when you were done starting an IV and we didn't have those safety caps on it, you guys used to just put it right there in the seat. Well, obviously times have changed pretty much, or pretty drastically. You know, now we have sharps containers everywhere. You know, we have multiple in the truck. That's something that we're going to want to make sure as soon as we start that IV, if you're not putting it in there directly, you are giving it to somebody safely to then put it in there directly. We do have that safety lock on it, so it is virtually impossible for a finger stick, but still we don't want that to have that possibility of accidentally sticking somebody of any sort. And obviously in general, like with blades, you know, you just don't want to ruin your own equipment too. You know, say something gets stuck around the bag or something like that, and you go to close the bag and something hits it, and now the needle comes right out of the bag. You just ruined your bag right there. We don't want that kind of stuff. So some review questions to think about with this section so far is, what procedures does the term body substance isolation refer to? And then also, what types of PPE do responders typically use during emergency medical calls? So these questions pretty much go directly hand in hand because of the nature of it. Obviously, when you talk about scene safe, BSI, the first thing on every medical call you're thinking of is your gloves. So that's the biggest thing right there. To move on to the next section, the objective 5 is going to be explain the process of patient assessment. So when it comes down to patient assessment, there's the basically one acronym that we're going to use in 2 different ways. So just on the normal responsive patient, we're going to go ahead and just use ABCs. Make sure the airway, breathing, and circulation are done. I know this is all stuff that we are proficient at because we're paramedics, but like I said, we're going to take it back a step and go back to our basis of some of these EMT-based skills that bring us to our core. So with that being said though, we have started to develop the situation of if they're unresponsive, we want to change that up a little bit. Instead of going airway, breathing, circulation, we want to go the CAB. We want to make sure that circulation is good, then airway, breathing, okay? So with that being said, when it comes down to that circulation, you're going to see a person and you're going to say whether they look like they are perfusing adequately or not, right? And that is why it used to be airway, breathing, circulation on these people for anybody, and now we've developed that situation in these unresponsive patients. You can tell when somebody is not adequately perfusing just off of their appearance. So again, when it comes down to the pulses present A, B, C, you're going to just go ahead and keep it that simple. Now, when the no pulse is found, based off of that presentation, you're going to see it. You're going to see that this person does not look like they're having any circulation going on, and by their appearance, say they're cold, they are pale, everything along those lines. You're going to go up there and you're going to check for that pulse, because if that pulse is not found, it doesn't matter if they're breathing or not. You're going to start compressions on them. So that is why, when with all of the science that has been found nowadays, is compressions save lives. So why are we hyper-focused now on the airway when we're going to go ahead and do compressions anyways? That airway will come, okay? So with that being said, no pulse, immediately begin compressions, and then the airway will be open afterwards, okay? So for the airway, tongue, foreign body, or foreign objects, fluid obstructions in the airway, or air just cannot freely travel through it. those are going to be the situations where we are going to want to manually, or if we need to use an adjunct as well, to open up that airway. If the patient appears to be talking and appears to be breathing without difficulty, you're going to assume the airway is clear, correct? So that is why a good initial patient assessment, hi, how's it going, is going to be your first sign of whether their airway is open or not. Now again, if the patient is unresponsive, their airway might be needed to be opened, whether that's, easy head tilt, chin lift, jaw thrust. But again, if they are unresponsive but have a pulse, that is where airway is going to be coming in place next, because we know they have a pulse. So yeah, like I said, airway needs to be then your next priority. The breathing. So you're going to place your ear next to the patient's nose and listen for the sound. And while you're doing that, you're also going to look, make sure the mouth and the chest is not moving around. You're not seeing any chest rise and fall, as well as that mouth, you can tell, is just staying nice and still. That means they're not going to be breathing adequately or breathing at all. With the circulation is also compressions. So that is why your C starts first in these unresponsive patients, because its circulation results to compressions. So again, checking for a pulse is the easiest way to determine this presence. We don't want to typically go straight to them if they are not conscious and go for a radial pulse, because you might not always find it based off of that blood pressure. If they truly are in cardiac arrest, you're definitely not going to feel a radial pulse, but you're also going to be more effective by trying that carotid pulse as well. So go ahead straight to the carotid pulse, because they might be unresponsive, but when it comes down to they're unresponsive but have a pulse, and you try to feel down there, you don't feel it. Well, you're thinking, well, shoot, they're in cardiac arrest now. Well, they're not, because they actually have a carotid pulse. Their blood pressure is just too low to get that blood flowing to the peripherals. So we want to make sure that we're staying just on top of the placement of where we are putting our fingers for this pulse check. So this just kind of goes into it as well. With that radial artery, yeah, typically, you're going to have a radial pulse on everybody, but we are going to want to make sure that we're checking that carotid, just because that pulse is going to be more profound in that spot. So, if your, textbook is just, I go straight to the radial pulse, I don't feel it, then you're going to want to go to the carotid. But you want to make it a better habit just to go straight to that carotid in people that are unresponsive. And again, just to summarize that, the person that's unresponsive does not have a pulse. You're going straight to compressions. Airway breathing will come after that. But to summarize anything that you can ever think of in this situation, unresponsive, compressions. So I know it's easy. We'll give it 1 second though to think about, what do the ABCs of a patient assessment refer to? Yeah, that is your initial assessment that we're going to want to go for, and it's just to make sure that we are going to then lead into the situation of CPR. So we're going to describe what CPR is, and obviously, as I said in the beginning of the class, this is going to be one of our skill stations. So alongside with this, I'm gonna basically go over it first, and then I'm gonna bring the mannequin over here, and we're gonna go ahead and I'm just gonna give you guys a visualization of what I want you to do. And then towards the end, before we're ready to test, we'll go ahead and have some practice rounds if you need to, or just anything like that. I know we do practice CPR a lot, so should just be able to give you these skill sheets, and we'll be pretty adequate at doing it when it comes down to it. But again, we're gonna pretend like we're going right back to our core, and we're gonna go to the basics on this. So CPR, what is it? Clinical death, cardiac arrest, biological death. Those are anything that's going to be causing this CPR situation. Whether it's clinical death, cardiac arrest, that is going to be heart stops, breathing stops. The heart is failing to pump any blood or oxygen towards the rest of the body, correct? So with that being said, it's typically going to be that the heart's inability to produce or transmit electrical pulses. Obviously, someone can be in cardiac arrest and need CPR when they are in VFib and VTAC. So that's not saying that they do not produce or transmit electrical pulses, but that they're not adequate electrical pulses. The next one is just a biological death. That's a cell death progresses to the point that the organ just cannot sufficiently flow blood to the brain or the heart. That's just your person that is ready to die. They're old. They live their nice life. Their body's just shut down now at this point. There's nothing we're gonna do about that other than attempt to give CPR. Hopefully these people all have DNRs at this point, but those stubborn people that don't. So that's why we're always gonna wanna give our best effort in these CPR situations. But you do have to internalize the fact that this is not always going to be people that we save. Typically never is these biological death ones. And those, like I said, are going to be those people that are in those asystole rhythms that typically are not going to be saved, no matter how good our CPR is, unfortunately. So when it comes down to those different electrical impulses that can be defibrillated, the VFibs, VTACs, those are going to be the ones that we're going to want to focus on the defibrillation, the outside electrical stimulus. When it comes down to it, it needs to be performed as quickly as possible. That is why pacemaker / defibrillators are put in people, because early defibrillation saves lives. So that is going to be what we also as firefighter paramedics or people in the field want to preach to business owners and everything like that, to have AEDs on them because of these situations. Obviously an AED is not going to shock the rhythm that can't be shocked, but if it is a shockable rhythm, we want to make sure that that's being shocked right away. So again, it doesn't take a paramedic to save a life when it comes to these AEDs. These defibrillators can do it on their own as long as there's somebody to hook them up. So that's why we want to get out there, do community education, and get things taken care of when it comes down to these defibrillators. So again, when it comes to defibrillators, they don't shock everything. Obviously, asystole, PEA, they're not going to shock. And as the layperson, they're not going to understand that. They think that everybody needs to be shocked because of all these movies and TV shows that are out there, that show them shocking asystole. That's just not what we do, because it's not a rhythm that you're going to basically get into a normal rhythm off of that. So when it comes to CPR, it's basically what we're doing is we're physically pumping the heart ourselves. We're taking that heart and we are pushing it to push the blood into the rest of the body. We're letting it come back up to then fill again, and then we're pushing it back out. We are forcefully doing that ourselves. As well as these respirations, we are doing it ourselves. They're artificial mechanical ventilations. We're doing that for them. So not only are we pushing blood to their body, we're also delivering oxygen to them, so that way those two coincide and then create the best outcome for these patients. That is why good CPR saves lives. And again, a layperson CPR, I'm not the biggest fan of this slide, just because of, if we can take advantage of community education, we can get into those situations where these layperson situations in CPR are almost better than we can do, because if they take pride in doing it and saving another person's life, even though they have zero medical background, it's going to be good. It is going to feel good for them, and it is going to be the best outcome for these patients that do go into cardiac arrest. So I can attest to you that not every healthcare provider CPR is top notch. Just because we might do it more, or just because we know we have a medical background, doesn't mean our CPR is going to be better every single time. So that's why we want to really focus on having the best CPR we can, but also teaching that layperson CPR as much as we can. Again, just becoming CPR certified for those lay people. We want to make sure that we're doing that for our public. And this just basically goes, the AHA and the Red Cross are considered the standard for CPR training and protocol. Typically, anytime you get CPR certified, it's usually going to be between Red Cross and AHA. Those are going to be your main ones that that do the trainings and along those lines of making the protocols for CPR. So these AEDs, those automated external defibrillators, those are going to be what saves lives, honestly, when it comes down to these shockable rhythms. Get them on as soon as we can. Make sure that, obviously, if we're just in this situation of we're lay people right now, we're not on the truck, we're not in the ambulance, we don't have equipment, we're at the store, somebody goes down on us, we want to make sure we're fetching that AED as soon as possible as we're starting CPR. Again, that'll be in our skill sheet that I will go over, but we want to make sure that we are getting that AED applied to that patient as soon as possible. And then the good thing is these AEDs talk to us. These AEDs tell us exactly what they want. So that way, a layperson can do it without any medical background because it's going to do it for us. If the AED is unsuccessful, we're going to keep proceeding to do CPR because maybe we might get them into a rhythm that might get it to shock correctly, or that, you know, if the shock is not needed, we're going to keep doing the CPR because that's what's going to give them the best outcome. Chest compressions. So, the biggest thing with chest compressions that we need to make sure is obviously the age differences when it comes down to what and how we're giving CPR. Those are going to be things that we're going to want to think of, which we will go over more in the next few slides. But also, the survivability really does depend on compression and just how successful we are with doing adequate compressions coincides with the survivability effect of these patients. Cardiac arrests are stressful, you know. We're not always the first ones on scene, you know, so the biggest thing when it comes down to CPR that's being done prior to our arrival, it's a stressful situation with these people doing it. We want to make sure that we're taking care of them as well as taking care of the person that's in cardiac arrest, obviously. If you have an extra hand, go ahead and make sure that we're taking care of the person that just did their best on this CPR. But also, we want to make sure we have our PPE on to start everything. So, obviously, we just did an entire section on BSI. Other than that, the biggest thing that we want to make sure that we're taking into consideration, not only for the patients, you know, just being the advocate of the patient, but when it comes to, you know, loved ones and stuff like that, if somebody's got irreversible causes, you know, they're already in rigor, there's no reason to do CPR and traumatize everybody. Also, you know, decapitation, you know, you're not going to get these people back. We do have our irreversible causes that are in our protocols. Just make sure we're referring to those when it comes down to that. We don't want to just give CPR to people that aren't going to be saved with 100% certainty. So again, as I was saying, the CPR, especially in layperson CPR, is going to be the number one, or compressions, excuse me, is going to be the number one thing that we want to harp on when it comes to these lay people CPR. Okay, ventilations, they will come, but it comes down to getting that blood flow again in this body before we want to care about anything else. But the full CPR does entail the chest compressions and the ventilations, because as much as it does benefit a patient to get that blood circulating, it does no good if there's no oxygen attached to this blood. All we're going to be doing is depriving that brain and heart and stuff like that, those vital organs, of oxygen that are necessary for survival. So as important as it is to get that blood flowing, we want to make sure that we're getting those ventilations in as well, which is why we're gonna go over it here in a second, but the biggest things are make sure that we're getting certified in true BLS healthcare provider level CPR and having a formal training. So for compressions on adults, first of all, obviously we want to make sure that they are not conscious, okay? So checking their responsiveness. Let me go ahead and grab one of the mannequins at this point. So, basically, like I said, we're gonna wanna make sure that this person is not conscious, okay? Get out of the way a little bit. So, checking for responsiveness. Sir, ma'am, can you hear me? There's no response. That is where then we're gonna make sure that they have a pulse or not, okay? That is where we're gonna be feeling right there in their carotid. We are going to make sure that they do not have a pulse, no more than 10 seconds, okay? Because obviously, as you can think, 10 seconds is a long time, especially when it comes down to your heart not perfusing, not pumping, okay? So, no more than 10 seconds. Make sure we're checking for that, that pulse. After that, if they do not have a pulse, you know that they're unresponsive, that's where we're gonna wanna activate EMS, okay? We're gonna wanna activate the communications in terms of getting an ALS unit en route. So with chest compressions, you're gonna wanna make sure that this patient is on their back, obviously, because we need to push on their chest. So with that being said, with it being on their chest, we have obviously the nipple line like this. We wanna make sure that we're right in the middle of the nipple line with our palm directly in the center there. We don't wanna be too low, we don't wanna mess up and break that xiphoid process. We don't wanna be too high because the heart, sits right about here. So we wanna make sure that we're staying right there with the palm of our hand in the middle, okay? As well as just obviously with a regular adult, depending on their size, you're gonna wanna make sure that you're putting a hand on top of each other. Sometimes you're gonna need to put a little bit more weight into it depending on how large the patient is, because we wanna make sure that we are still pushing down about 2 inches, okay? Obviously if they're a little bit larger, we wanna almost think about 1/3 of the body. On a normal person, that's about 2 inches. Obviously it might increase as the person gets a little bit larger, just because there's so much more skin and maybe fatty tissue, anything like that, that's kind of covering that spot. But for the most part, that's going to be our location of our CPR. With that being said, I want to make sure that the back is, or the head is tilted a little bit backwards to open up the airway. We want to keep our elbows straight. Okay, so now I'm going to grab a chair here so we don't have to get on the ground. Assume this is the ground. We've got our person on the ground with the head slightly tilted back. That is going to be something that we can always direct another person for. So this person is now to the side. I've got my hand placement correct where I need to. I like to overlap my hand and kind of do one of these. So when I'm doing that, basically you want to make sure that when your knees are as close to that patient as possible, arms straight, shoulders directly over the patient. So now I'm not going to be sliding on them. I'm not going to be pushing to the side. I am going directly down, okay? So when I'm going directly down, as you can see, I'm going to push towards the next one so it can give us more information on that. But again, arms locked, shoulders directly over the site of compression. The 2 to 2.5 inches, obviously depending on the size of the patient, is going to be very, very different on that. But anybody that is bigger than an infant, so any child, anything like that, is going to be that 2 to 2.5 inches, okay? Especially as we see, kids are getting bigger nowadays. They're almost like adults. So we're going to go ahead and do that. So when you're going, I got my knees down directly next to them, shoulders in line with my compressions, and I'm going straight down. When I'm doing this, I'm going down to the point where I feel the 2 inches is there. I'm going down almost till I find a little bit of resistance. We do have so much, musculature and bones in there that we're not gonna be able to go down as far as we think. So you do want to go far enough. Typically, you're gonna, crack those ribs. It's just all the cartilage. That's all we're doing. We're creating that room for us to then adequately compress the heart, give it that compression that we need. But other than that, like I said, it really depends on, the depth really depends on the size of the patient, but typically it's gonna be 2 to 2.5 inches, okay? And when doing it, we're gonna wanna make sure giving it the complete recoil so that way that blood can flow back into the heart, so that way when we push back down, we're gonna be adequately pushing enough blood, and we're not prematurely pushing a little bit of blood. We wanna make sure that heart is filling up as complete as possible. So When we're doing this, we want to make sure that we're doing it at a rate of 30 to 2. 30 compressions, 2 respirations. So these 2 breaths that we're going to be putting into this patient's mouth, you know, in our situation, we do have BVMs that we're going to use. In a layperson situation, you might not have that capability. You might have a mask that you can put on them, a pocket mask, that we're going to be able to use. And or if not, then I typically am not going to be putting my mouth on somebody else. But for the sake of the lecture, I'll go ahead and we're going to talk about breathing twice in the victim's mouth while holding the victim's nose closed. Okay, because obviously if we're going to breathe out, we don't want the breath to go right back out their nose. We want to pinch their nose and breathe directly into their mouth, covering their whole entire mouth. And again, if we have a BVM, just making sure we have adequate closure on the nose and the mouth, giving each breath over a second and making sure that we get the correct amount of tidal volume in there. So when it comes down to adults, we want to do it at a rate of 100 to 120 per minute. So obviously we're doing it at a 30 to 2 pace, but you want to think of that 30 being in that half a minute type deal or anything along those lines, half a minute, maybe a little bit less, because you're going to be doing those compressions. Actually, sorry, even less than that, because we're doing 100 to 120, which should be a compression almost 1 to 2 per second. After that, you're going to continue until patient moves, breathes normally on their own, regains consciousness, or until other providers with greater training arrive. So obviously for us, we are going to be these providers with the highest training, but say we're off duty, we're doing CPR, as soon as that ambulance comes, we can pass it along to them as well. But making sure that they are completely ready to take over CPR. Again, in these situations, we're typically they're not gonna start just moving out of nowhere. They're not just gonna miraculously start gaining consciousness, but they might start breathing on their own. That is a situation that we wanna be aware of. And not only that, just check for that pulse as well, and that's gonna be the situation that we're gonna be looking for. Again, the responders should be rotating about every 2 minutes, which is every 5 cycles. That's going to be our normal cycling of responders. Typically, there's going to be the 2 responders. It's going to be the easiest way to do it. So note, while performing chest compressions, it is often common to hear or feel the patient's ribs break. As I was saying, you know, that's just going to be a common thing. If you're not, you know, breaking ribs at first, you're probably not going deep enough or letting that chest completely compress. So as it comes for children, it is going to be a very similar thing, especially nowadays. We're trying to treat children like we do adults when it comes to these situations. So we want to make sure that these kids are, first of all, unresponsive and no pulse. When we check these pulses, we're never going to go down to the radial anyways, just because sometimes, you know, baby fat, all that stuff, we're gonna get difficult capabilities of hitting there. So we want to go brachial, but again, keep at the carotids. Never check both carotids at the same time. Just gonna put that out there. If there's no pulse, then we're gonna then put these kids back onto a solid surface as well, just like on patients. We don't want to do these compressions on beds or anything that will move with the patient. Put them on a solid surface, begin CPR. Make sure that dispatch is notified and an ALS unit is dispatched. So when it comes down to larger children, this is going to be the kids that, you know, not necessarily are in puberty yet, but are definitely of adequate size when it comes down to it. Like I said, some kids are you know, getting larger earlier, and just use your strength accordingly. So if you feel that you can use one hand, go ahead and use one hand. If not, again, we're going to go ahead and go to that two hands next to the patient and do our CPR adequately. Now say they are a little bit smaller, and 2 arms or 2 hands are just going to be a little bit too much. We're going to go way too deep without any feeling of doing so. So again, adrenaline is going to be a big factor in this as well. So you're going to see a smaller child, You know, I can then go one compression and do that. Again, keeping my shoulder in line with my compressions. That way I'm not having to, you know, switch off. But if necessary, you know, you do 130 round here, you go to the next 30 and do that, okay? But you wanna make sure that you're giving adequate compressions. Say your one arm starts to get a little bit less depth, then you're gonna wanna then move on to that 2 arms, okay? Just to go through a little bit more stuff, it is again very similar to the adult. Your arms, your hands are still going to be in the same spot, still going to be about the 2-inch mark, 100 to 120 per minute, the 2 breaths every 30 compressions, and you're going to do it until the patient gains conscious, moves, pulse comes back, anything along those lines, or another higher level of care comes. That's just reiterating that large children can be considered adults when it comes to these situations. So, infants, that's going to be a big difference when it comes to these compressions. And the style of compressions, you know, how much to do, and then also the depth, okay? So, again, determine the status. Most cardiac arrests when it comes to infants are usually airway related, whether it's just they're not able to, you know, the respiratory drive has just diminished, or they have an airway blockage of any sorts. So with that being said, if a child is unresponsive, pulseless, apneic, you're going to want to make sure that you're going ahead and checking the mouth to see if you can remove anything out of the airway that is obvious, okay? You don't want to sit there and waste too much time on it, but the earlier we can remove that object, the faster we can get adequate oxygenation to this patient to then give their oxygen drive back, okay? So the biggest thing, again, with that being said for children, it almost goes back to the airway breathing circulation, just because of the fact that their airway is entailing the fact that that's probably why they're unconscious. So for infants, you don't want to ever go to the carotid just because of just how tiny their bodies are, and they typically have a little bit too much extra fat around their carotids as well as their wrists. So the brachial is always the preferred method in checking pulses for infants. Again, if no pulse, begin compressions, have another responder, or it's just somebody, another layperson, get extra an AED as well as the emergency care. So this one, there's 2 different methods when it comes down to compressions for infants. So we do not have any infant mannequins here because that is not on our skill sheet, but we will go over it. So we're going to assume that this is a very tiny human and not an adult size. So the biggest things when it comes down to this is usually about the 1/3 of the depth of the torso. As I said, every infant's going to be different size. You're going to have, whether it's the little preemies that are super tiny, those might be the people that you're going to use just 2 little fingers, or your 2 fingers, and you're just going to push down, okay? Because I don't need my full double hands to push 1.5 inches or 1/3 the depth of the torso on a tiny infant. That is why it is going to leave it up to your discretion again, depending on your strength, adrenaline, all that stuff. But go ahead, it's always better to start less to then more, because if I go ahead and just go straight to my incirculating thumbs and push down and I go too far, I can cause a lot of damage to those lungs and everything like that. So I'm going to go ahead and I'm going to start with those 2 fingers just in the center of the chest, just like you would with your palm. Go ahead and make sure that you're able to do that. So again, if I move on to this and I cannot adequately give a correct depth for a compression, I'm going to then go to what's called the incirculating thumbs. So basically you're going to go ahead and kind of go over the patient and basically encapsulate with almost a W, getting there and then pushing both thumbs down in that correct adequate spot in between the nipple line, just mid-sternum right there. So again, if the patient's still unconscious, you're giving CPR. When you're doing your ventilations, go ahead and just make sure the airway that there is, because doing compressions can cause sometimes a pressure difference, and sometimes it can push something up if it is an airway obstruction that you might be able to see eventually after doing compressions. So biggest review question here is, what's the purpose of performing chest compressions during CPR? And then how is the process of performing chest compressions for infants and younger children different than adults? So take a few minutes or just a minute or so just to think about that. Again, I know that we're all paramedics, but we're gonna think about it just as much as we need to, okay? All right. So on to, again, discontinuing your CPR. Those are gonna be whether you're gonna obviously periodically assess the situation. Say we're there on an ambulance as medical professionals, we have criteria that we are in our protocols that we have to abide by in order to discontinue these CPR attempts. But we're also going to periodically reassess the patient throughout our CPR time. Making sure the patient has not moved or regained consciousness, the patient has a pulse, patient's breathing, or you hand over the care to another provider. So again, we're going to take it into our own consideration as the field, where we are going to discontinue if typically we get a pulse back, or if we've done all of our safe measures and there's nothing we can do at this point. We're going to go ahead and contact the physician to instruct us to stop. So as I was saying, with the situations that are just, irreversible, cardiac arrests are very, very stressful situations for family. Not only do we have to take care of the patient, but we also want to make sure that we are providing care for these families. Hopefully there's a police officer on scene. That's usually who we kind of result to, taking family, helping them be consoled, everything along those lines. Sometimes families don't see things in our eyes that we're doing everything we can to save these patients. Sometimes they think that there's more more to be done, and those are situations that we want to make sure that at the end we are going over this event with the family, letting them know what we did and why we did it, and that it just did not work. Okay. Again, sometimes, when your CPR is not working, the patient just is staying in cardiac arrest, they don't have a pulse, they just never come around, and there's times where it can anger somebody, just because you're feeling like you're doing everything you can. Obviously, if you notice somebody like that, one of your crew members, pull them to the side too afterwards and let them know that everything, happens, that there's sometimes this happens. But speaking calmly, and then always making sure that you are adequately describing the situation, that this person is dead, and that there's no further measures that we can do for them. So think again, what are some points that you would discontinue CPR? Or think about situations in your guys' careers that you've discontinued CPR when you didn't think that it should be discontinued, or you got angry that you had to discontinue. All right, good. I feel like this is a good stopping point as well. Let's go ahead and take a 5-minute break. The CPR section is pretty big, and I know that we have our skill sheet. So go ahead and take 5 minutes. If you need to, look over that skill sheet again, just so you can put everything together, whether or by the fact that I was doing it up here and what you're gonna have to do on our test, okay? All right, now that we're all back, let's go ahead and get going. Go through the rest of these slides here. So this next learning objective is going to be describing methods of controlling bleeding, okay? So bleeding control, whether it's the fact of somebody's hemorrhaging, even as little as a nosebleed or anything along those lines, we got to think of what blood is meant for the body. So blood transports oxygen and nutrients to the cell. So when you're bleeding, you're depriving the rest of your body with that adequate nutrients and oxygen. So we want to maintain blood flow and volume because it's extremely important for the rest of our body, organs, everything along those lines. And then be prepared to stop bleeding in victims or patients, in our terms. So some of the big ones, as you can see, see if I can do. It's the other one. Oh well. But the biggest things here, as you can see, laceration. Those are going to be any of those. They could be a clean laceration. It can be an ugly one. Any cut though is really considered a laceration. The punctures, those are usually be any bullet holes, stabbings, anything like that. Anything that has penetrated through multiple layers that is not just a cut. The next one is our abrasions. So as you can see, it's just kind of we can call it like a skin tear, anything like that, your rug burn, just where it's breaking a few layers of skin, but it's not completely just a straight line. It usually takes up a pretty good surface area. So the biggest things is the type of bleeds that we're going to be needing to be aware of. So the arterial bleeds, those are going to be your main bleeds that we're going to need to basically tourniquet these. Okay, we want to make sure that blood is not just spurting out and we have no control over it. So the arteries, those are going to be the ones that the blood is being carried away from the heart, which is why they're typically carrying so much more pressure to it, because the blood is being pushed from the heart, so it's going to have more pressure to it. It is bright red, so those are going to be one of the things. So it's spurting and bright red. Those are going to be your big signs of it. Yeah, some of your main ones are your femorals, which are down by your groin, your brachials and your bicep. You've got your radials by your wrist. Those are some of your main ones that we're going to be focused on. So with the arterial bleeds, it is a true medical emergency. We need to get these bleedings to stop, okay? The biggest things, don't delay transport for anything else. And they can be difficult to control sometimes. But again, tourniqueting and just packing it, putting a lot of pressure on it is going to be what we need to do. Another thing you'll probably see is the pulsating of the blood. Venous bleeding, now these will be the ones that are less serious, depending on the situation of the patient. Sometimes they're on blood thinners. Venous bleeds can be dangerous. So these are going to be the ones where the blood is moving back to the heart. So it's not really too pressurized. The blood is darker. And it's just steady flows. It doesn't spurt or anything like that. It's just going to be a nice constant leak. Other than that, like I said, it is darker. Capillary bleeds, these are going to be the ones that are just super superficial. These are going to be the ones that are in between the arterioles and the veins, where the oxygen, nutrients, and the blood are delivered to the cells. It moves really slowly, so these bleedings are going to be a lot less serious in every aspect of things. This one, just a little bit of pressure usually controls these. Again, superficial, limited bleeding typically, just put some pressure on it. But with this is a main spot to be taken care of. Make sure that when we are putting pressure on these or applying gauze or anything like that, make sure that they are clean. And we should make sure that we're keeping the wound clean and bandaged up. What are the three types of bleedings? Obviously, we just went over it: arterial, venous, and capillary. Provide an example of each of the following types of bleeding: arterial, venous, capillary. Those are the situations where, just think of, for our situation here, go ahead and think of situations in your careers that you've experienced all three of these. Give it a second, move on. All right. So the methods in terms of controlling external bleeds, that direct pressure, elevation, and a combination of both. If when in doubt, elevation with direct pressure is always going to be your best decision there. Following protocols and standard procedures, proper PPE. Obviously, if it's spurting blood, you might want that whole face shield on with the glasses and everything like that, just because you don't want it in your face. And then again, for us, we are trained professionals. We can use tourniquets to stop these bleedings, but that's not everybody out there. So direct pressure, these are the ones with a gloved hand. We're gonna wanna put gauze on that wound directly, okay? Putting pressure. If the bleeding keeps going, apply more gauze. Once that, if that does help, then we're gonna go ahead and bandage that right away. If not, we're gonna go ahead and, keep adding that gauze layer, and then wrap it with more direct pressure. The best thing again for this severe bleeding is just as much direct pressure as you can. Keep packing that wound. Elevation. So when you think about why you use elevation, obviously the higher above the heart you have it, the less or the gravity kind of takes everything away. So you don't have to worry about if you're bleeding in your wrist. There's gonna be less blood flow to that wrist if you keep it above your heart. So it's basic anatomy with that. Again, just think of some main methods for controlling external bleeding. Internal bleeding, this is going to be the difficult ones that we're going to have to deal with in the field. It's not always super obvious. The spaces in the body that can hold blood sometimes can be pretty substantial without any signs and symptoms until it's too late. You just want to look into the mechanism of the injury that's causing these issues, car accidents, stuff like that. Whether they hit a steering wheel, say their bike, they go over their bike, those handlebars can go right into that spleen, it can cause some internal bleeding. So some of those things that we're going to look for is bleeding from different openings, the mouth, nose, rectum. Sometimes it could just be a bloody nose. Sometimes it could be coming up from the esophagus, anything along those lines, especially the rectal bleeding. Sometimes it could just be hemorrhoid or anything like that, but other times it could be caused by a GI bleed. But they're going to be painful, swollen, usually a rigid abdomen because all the blood is pooling in there. Bloody stools or urine. Sometimes they can be, depending on where the GI bleed is, if it's an internal one, they can have the cough emesis, vomiting. And signs of shock, cool, pale, clammy skin. That's going to be the hypovolemia setting in. Again, traumatic causes, gunshots, stab wounds. Gunshots are going to be the big one. For anyone that's ever ran on them, gunshots do not always just penetrate and stay in one straight arrow or straight line. Sometimes they like to dissipate, causing extra damage to the surrounding areas of the body. Yeah, uncontrolled internal bleeding is medical emergency, obviously. When you're bleeding into some of that dead space in your abdomen, you're losing a lot of blood sometimes. Without any of these signs until that shock comes in, and then we're going to have other things to treat. Signs and symptoms of some of those internal bleedings. Just take a second on that. So a good segue from that internal bleeding, because obviously shock is going to be a sign, a later sign that's going to set in. We're going to go over some of that shock management. So what is shock? Shock just basically means the body's unable to adequately perfuse the tissue in it, the organs, body, everything along those lines. So that's typically just the blood is either being shunted from some of those vital organs or just not able to adequately push to those spots. Some of these types of shock, hypovolemic, cardiogenic, and neurogenic, those are going to be situations based off of the true mechanism when it comes down to these. So those are going to be more subcategories into that, but we won't get too in-depth because this is just a provider first aid. So there's no reason to go too far in depth. We're all paramedics. We all know those in-depth portions. But to break it down easy, for this course, we're going to break it down into trauma, anaphylaxis, which is obviously an allergic reaction, severe allergic reaction, and then sepsis due to an infection. And then other medical emergencies, like I said, anything related to the heart or the brain can also cause these shocks. Hypovolemic, that's just obviously when you lose too much blood. Your volume of blood just does not adequately perfuse the rest of your body. More than just giving them fluids, we need to make sure that we give them blood, because that's the only thing that's going to obviously perfuse with oxygen. Fluid does not just obtain oxygen, so we need to make sure that the blood is being given back to them. So getting them to an emergency room, getting them the blood they need. Cardiogenic shock, like I said, that has to do with anything with the heart. So anytime the heart has the mechanism has caused damage to the heart or damage to the capability of pumping the heart adequately, that's going to be those situations that are causing cardiogenic shock. One of the main ones that we see is MI, myocardial infarction, a heart attack. Neurogenic shock, so those are any times that the blood vessel expand and contract due to brain signals and regulates blood flow. So whenever that brain is unable to tell these blood vessels to expand and contract, constrict, dilate, stuff like that, those are going to cause issues getting blood to the brain. So those can sometimes be spinal cord injuries or anything along those lines. Those are going to result in overexpansion of blood vessels and decreased blood pressure. So when blood pressure decreases, blood's not able to pump to those vital organs like the brain. So again, spinal injury and head injuries are going to be your main cause. It is a container issue because the container is damaged. Anaphylaxis, obviously severe allergic reaction, and then sepsis, usually a severe infection, and it's usually a later onset to it. What are the 3 most common types of shock? Go ahead and think about that for a second. Alrighty, we are on the home stretch of shock, so we're going to make sure for the signs and symptoms of it. Again, the reason that shock is setting in is the body's not adequately being perfused, so it's not getting the oxygen that it needs to. So some of these main things that we can associate with it is just the internal body functions are carefully adjusted to achieve optimal results. So when the body is starting to go through shock, everything is being shunted away from the peripherals. So everything is staying internally because everything's shifting its need to the vital organs, okay? It may be able to keep with that periodically for a time frame. It's called compensated shock, but then it goes into the uncompensated. So afterwards, it starts to negatively be affected. And when that starts to happen, different signs are going to start leading to that. This is a main one, the pale, cool, moist skin. Because obviously, if your blood is being shunted from your peripherals, what's going to happen? The blood is not going to adequately pump to your skin, which is then going to cause it to start to get cold and lose all its color and stuff like that. So that's a big one. The next one is that tachycardia, that rapid heart rate, and the tachypnea, so your rapid breathing. Those are going to be your 2 main other signs and symptoms that are going to occur. After a while, it's going to start causing some nausea, vomiting to an effect. Confusion, altered mental status will hit, dizziness, dilated pupils, and eventually a loss of consciousness. Some of the signs and symptoms, obviously we just went over last slide, so it should be pretty fresh in mind here. The treatment for shock. So again, depending on what type of shock we are dealing with, they're all going to need different treatments, but some of the main things that we're going to want to make sure we get to. So if you think about shock being the inability to adequately perfuse due to lack of oxygen, oxygen administration is going to be our big one. But in the field, we can't do too much for shock depending on what the situation is. So we are going to want rapid transport to the hospital because that can be the best outcome for the patient. But keeping wounds, if that's your hypovolemia, we want to make sure that we are keeping that circulation intact. Oxygen administration, obviously the bleeding control. Cover the patient's body, because If their body's already cold, again with the oxygen administration, we want to make sure that we're preserving that body temperature, getting it as warm as possible. Treatment basically is where this is going at, and we just went over that. So that concludes the end of the lecture portion. So we're gonna go ahead again, take another 5 to 10 minutes. At this point, we are all finished with my lecture. I've gone over basically everything necessary to pass this test. The test again is 13 questions. I'll kind of go over everything back when you guys get back in this room. But to proceed with the rest of this class, we're gonna go ahead and take our our written test as well as our practical test. And we have all of the necessary equipment already here for you. So if you on your break want to go ahead and mess around with it, go through your skill sheets, and if you have any questions, I'll be here and we'll get it done, okay? So go ahead, take about 10-15 minutes if necessary. If we're all back earlier, we can go ahead and get started if we need. Okay, everyone, so we're gonna go ahead and get started on the skills assessment of oxygen administration by non-rebreather mask. Basically with this, I'm just gonna go over each step so that way we are prepared. I want you guys to follow along with your skill sheet as well with me, so that way we can go ahead and knock this thing out, okay? So first things first, when it comes to the oxygen administration, you just wanna make sure that you have all of your equipment, okay? So I've got my oxygen tank, I've got my non-rebreather, my regulator, the key for the oxygen bottle, and then also my mannequin as my patient. So the first thing we're gonna do is we're gonna take and verbalize appropriate PPE. So with that being said, go ahead and put some gloves on when we're doing this. After that, we're gonna then make sure that we have all of our equipment with us. And at that point, we're gonna go ahead and get to our oxygen bottle. So the first thing we wanna do is just make sure, inspect the bottle, make sure it's all in good shape. And then we're going to crack it just temporarily, just to make sure that it is working order. So after that, we're gonna go ahead and assemble the regulator to it, okay? So you're gonna make sure that the 2 prongs go down on that side. Once it's at that point, you got your O-ring in it as well, so that way it's gonna stay nice and tight. All right, so we've got this thing nice and tight. The next thing we're gonna do is turn on the bottle. So we turn on the bottle, I check my pressure, make sure that we're in good working order. I'm checking to see if I have any leaks. I can't hear any, can't see any, can't feel any, all that. The next thing we're gonna do is crack it open, just to make sure that the regulator portion actually works. After that, we're gonna go ahead and hook up our non-rebreather. Make sure nothing's tangled up. So we're gonna hook it up to the correct port, and we're gonna turn it on to about 10 right now. Fill up the reservoir. And I can bump it up to 15 if I'd like at this point. Once it's there, we're gonna go ahead and place it over the patient's head. Make sure that the nose and the mouth are covered completely. And at that point, we are all finished. So you can go ahead and turn it off. Okay, any questions on that one? No? Okay, great. So at this point, now we're gonna go ahead and move on to the next skill assessment. So the next skill assessment is going to be the cardiac arrest management with an AED, okay? So, disconnect all this. So with this one, you're gonna make sure that you have the correct equipment as well. So I've got my mannequin, got my AED, and I have my my oxygen delivering device, which is gonna be the BVM in this case. So, as the other one stated, we're gonna go ahead and take BSI precautions. So we're gonna put our PPE on, we're gonna have our gloves on at this point. Then we're also gonna make sure that the scene is safe. Okay, so basically first thing, gloves on, scene safe. And after that, we're gonna go ahead and check the patient's responsiveness. And as I went up over our slideshow, you're gonna make sure that you do this no more than 10 seconds. Okay, so all in together, you're gonna check responsiveness, give a sternal rub, give a nice little shake, say, sir, ma'am, are you there? No response, that is when we're gonna go ahead and activate our EMS agencies, as well as direct somebody to get your AED, okay? So once those have all been done, you're gonna go ahead and then check for a pulse, as well as breathing status. So you're gonna go ahead, put it on there, just as the slideshow said. Gonna go ahead and check for the carotid pulse, as well as listen and feel. I have no breathing, I have no pulse, the patient is unresponsive. At that point, we are gonna go ahead and get right on the chest and do our compressions, okay? So with those compressions, you wanna make sure, as I went through on those slides, is you really wanna make sure that you're getting adequate chest rise and fall when it comes down to, or the correct depth, my apologies. You wanna make sure that the correct depth is being hit, as well as making sure that you're hitting the right ratio, okay? Hitting that about 100 to 120 per minute, which will then break it down because you're only doing 30 to 2 in this case, but you wanna make sure that you're still hitting that pace, okay? Also, you wanna make sure that you're letting it completely recoil before you're going back down, as well as the correct depth around 2 inches, okay? So then once you're doing that 30 to 2, 30 compressions to 2 breaths, that is considered 1 cycle. You're gonna go ahead and complete 5 of those cycles, which again will be about 2 minutes. After that 2 minutes is up, you're gonna go ahead then at this time, your AED has been fetched, you have it with you, you're gonna go ahead and turn it on, and then follow the prompts. So the first prompt it's gonna ask you to do is connect the pads. You're gonna connect the pads, plug it in, and then it's gonna wanna analyze the rhythm immediately. Once the rhythm is being analyzed by the AED, you're gonna have everything stopped at this point. So that second rescuer is going to stop CPR, and it is going to analyze the rhythm. Once it's analyzed, it will then say it needs to be shocked. So you're gonna go ahead and it'll start charging. Go ahead and tell everybody to stay off it still. It is gonna direct you to shock the patient. At this point, you wanna make sure that everything is staying clear of this patient. You're gonna then deliver the shock once it is. As soon as the shock has been delivered, you are going to direct that second rescuer to get back on the chest and do compressions. And at that point, you are all finished. So again, that will be the cardiac arrest management with an AED. Does anybody have any questions on that as well? No? All right, great. So we're gonna go ahead and take about another 5-minute break just to go over all that at your guys' leisure, at your discretion on how much you need. And then once we reconvene, we'll go ahead and get the test done, okay? We'll start off with the written test and then move along into the practical test, okay? No questions? All right, you guys are good. Alrighty, so at this time we're gonna go ahead and do our chapter 23 quiz. It is the written portion of the exam. So there are 13 questions on it. You're gonna go ahead and answer every single one of them, writing the letter out as well as circling the letter for me. Go ahead and put your name and date on it as well. Today is the 3rd of February. You guys have any questions before we get started?
No, sir.
Alrighty. Make sure to keep eyes on your test only, please. help you. And then you go ahead and break. Thank you.
Yep.
Thank you. Go ahead and take a 5-minute break. All right, John, you are up now for your practical of the oxygen administration by non-rebreather. Do you have any questions before we start?
No, thanks. Just doing
Thanks. All righty. You are ready whenever you're ready to start.
BSI scene safety. Come up, grab my oxygen tank, check it, see if there's any dents, anything like that. Looks like it's messed up at all. Go ahead and perfect it and any dust or debris off of it. Good there. Grab my regulator, make sure I got my O-ring. Fit it in here. Tighten her down. Open it back up, see if it's any leaks going. Nope, we're good. Got it all the way open. Still got flow. Grab our oxygen bag. Hook it up to the regulator. We're gonna go to 10. Start out and go all the way up to 15. Fill our bag, make sure we got good pressure. Once our bag's filled, take it to the patient, put it on their nose, go around. Head sticky like mine. Then we're gonna tighten it, grip the nose, make sure we got a good seal there. And maybe breathe in.
Very good. You hit all the necessary points. Passed with a perfect 11 out of 11. Do you have any questions or concerns for me?
No, sir, thank you.
All right, good job. All right, Kyle, it is your turn now for the oxygen administration by non-rebreather practical. Do you have any questions before we get started?
No.
All right, go ahead.
Okay. BSI scene safe. Okay, I've got my equipment here, got an oxygen tank. Let's see, I got the key, got the mask, I got the regulator, and I got my patient. So first I'm gonna go ahead and crack the oxygen tank to make sure that there's oxygen in it. Sounds like we're good there. Okay, so next I'm gonna take this, I'm gonna line up regulator, make sure that there's nothing wrong with the O-ring. O-ring looks good. Put that in place, have it seated, tighten it down. There you go, looks like it's on there. Turn on. Listen for leaks. Don't hear any. Test it. It's working. Okay, so now I'm going to go ahead and hook up the tubing and fill up the oxygen reservoir. Alright, that is filling up appropriately. So next I'm going to take this and I'm going to put the snugly on the patient's face.
Very good. We're all good to shut her off. Do you have any questions before we conclude?
No.
All righty. You went ahead and passed with all appropriate points awarded.
Okay.
And good job.
Awesome.
All right, Dan. So this is gonna be your skill practical here. We're gonna do the oxygen administration by non-rebreather. These are your materials. So go ahead and start whenever you are ready.
Scene safety BSI. Check my tank for any damage. We'll burp the tank, make sure the airway's clear. Assemble my regulator. Working on my tank. Listen for any leaks. Don't hear any leaks. Prepare my equipment. Turn on my oxygen flow to 10 to 15. Refill the reservoir bag. And apply it to my patient. Adjust it.
Very good. You hit all necessary points on that. You passed with a perfect score. Good job.
Thank you.
Do you have any questions for me?
No, sir.
Good job. All right. So, John, this is going to be your practical now for cardiac arrest management with an AED. Whenever you are ready, you have your patient right here.
Okay, got all my equipment, all that good stuff. BSI scene safety. I'm gonna come up. Sir, man, can you hear me? See if there's any responsiveness. If there's not, I can try a little sternal rub. Then I'm gonna get down, check their pulse. I'm gonna look, listen, feel, see if I see any breathing or feel any breathing, hear any breathing. And I don't feel like I have a pulse. Not breathing.
No breathing, no pulse.
Okay, I'm gonna have one person go get me an AED. You call 911 for me.
AED is present.
And I'm gonna go ahead and
911
begin
called.
my compressions.
Okay.
All right. So, get my hand in the right position. Six, 7, 8, 9, 30. Go ahead and use my bag since I have it available. Take no more than 10 seconds. Do a head tilt chin lift. My CE grip here. Squeeze form. 1 breath. 2, making sure I don't have any leaks. And then go back.
Good job. One cycle is finished.
Six, 7, 8, 9, 30. We're just gonna go ahead and practice a little mouth to mouth. This time we're gonna pinch his nose. 1 breath. 2 breath. Making sure we have good chest rise.
2 completions.
Six, 7, 8, 9, 30. Still waiting on my AD, I guess.
Yep. Your AED
Okay,
is
chin
will be
lift.
here shortly. It's 3 full cycles.
Should be my last cycle.
This time your AED has arrived. Another, your partner has arrived as well to do CPR.
Okay, I'm gonna have them start doing compressions while I take the AED here. Go ahead and turn it on.
Apply pad.
We're gonna follow these little instructions. So I peel it off, stick it on the patient's chest, peel it off, stick it there as the pictures show. Plug into my indicator. All right, don't touch the patient.
Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock now.
Okay, I'm clear, you're clear, we're all clear.
Everyone's clear?
Shock
Shock's delivered. We're gonna have our Partner, continue compressions now at the
Begin
metronome.
CPR.
Alrighty, you are all complete. Good job. You've hit all necessary points to be awarded. And other than that, you have passed. Do you have any questions or concerns?
No?
Great job on the CPR and the ventilations.
Thank you for finishing.
Alright, Kyle, it is your portion now of cardiac arrest management with an AED for the practical. Do you have any questions before we get started?
No.
Alrighty, floor is yours.
All right, BSI scene safe. Secure. All right, I arrive on scene, find a patient on the ground. Sir, can you hear me? Not responding. Sternal rub, still not responding. I'm gonna go ahead and call for immediate medical assistance.
AED
Get
has
an
been
AED.
retrieved.
Okay.
EMS is called.
I'm gonna look, listen, feel. Do I feel anything?
You do not
Hear
feel anything.
Okay.
The patient is unresponsive, not breathing, and pulseless.
Okay. All right. The airway appears to be clear. I'm gonna go ahead and start chest compressions. All right, it's 30. Go ahead and get seal here. 2 breaths. Look for chest rise.
There you go. That's
Start
completion
again.
of one cycle.
One. Go ahead and do the same. Head to the chin lift. 1 breath. 2 breaths.
Completion of 2 cycles.
Okay. Another.
Completion of 3 cycles.
Okay.
Completion of 4 cycles.
Okay.
Your AED has arrived.
Okay. All right. Do I have medical assistance here also?
Yep. You
Okay.
have a second CPR rescuer.
All right. I'm gonna have
An
them
AED has
continue
arrived.
chest compressions.
Chest compressions have been resumed by second rescuer.
All right. I'm gonna go ahead and turn on the AED. I'm gonna get the pads out.
Apply pads to patient's bare chest. Plug in pads connector next to
Place
flashing
them where
light.
they're supposed to be here. There we go.
Apply pads. Plug analyzing
Pads
heart
are
rate.
on. Analyzing. Stop compressions.
Do
Compressions are
not
stopped.
touch the patient.
Okay. Everybody's clear of the patient.
Everybody is
Shock
clear of the patient.
advised.
Okay. Everybody's clear.
Charging.
Charging.
Stay clear of patient. Deliver shock now.
All right.
Press
Everybody's
the
still
orange
clear.
Everyone's clear.
Now.
Okay. Shock delivered.
Shock delivered.
Shock
Okay.
has been delivered.
Chest compressions resume with my partner.
Chest compressions have resumed and you are all finished. Good job. All right, Dan, it is your portion now for the cardiac arrest management AED of the practical testing. Do you have any questions before we get started?
I don't believe so.
All righty, the floor is yours.
Okay, scene safety BSI,
Scene safe, BSI, prepared.
check responsiveness.
Patient's
Shake and
unresponsive.
shout. Look, listen, feel on the same side of patient. No breathing, no pulse.
Patient is breathless and pulseless, unresponsive,
I need you to go get EMS, somebody get me an AED.
AED and EMS are requested.
Okay, start compressions. Give a breath, check for chest rise. Another breath. Resume CPR.
One cycle is complete.
Good breath, checking for chest rise. Second breath. Resume
Two cycles
CPR.
have been completed.
Check for chest rise.
3 cycles have
Resume
been completed.
CPR. Breath, check for chest rise.
4 cycles have been complete.
Resume CPR.
Your AED has arrived.
Give a breath, check for chest rise. Second breath, check for chest rise.
A second rescuer has arrived.
Okay, I'm gonna have my second rescuer continue CPR.
CPR is resumed with second rescuer.
I'm gonna set up my AED. Start by turning it on. Place my pads where it
Apply
shows.
pads to patient's bare chest. Plug in pads connector next to flashing light. Analyzing
connected.
heart rhythm.
Stop
Do
CPR.
not touch the patient.
Checking the rhythm.
CPR has been stopped by
Shock
other
advised.
rescuer.
Shock is advised.
Charging. Stay clear of patient. Deliver shock now.
Okay, I'm clear, you're clear, everybody's clear?
Everybody's clear.
Shock delivered.
Shock has been delivered.
Begin
I'm
CPR.
gonna have my partner start CPR again.
CPR has been started again by the second rescuer. You are all complete. Good job. You have passed with all points awarded. Good to turn it off. Good job. Do you have any questions or comments? Okay, now that everybody's back, I just wanted to say thank you guys for allowing me to give you instruction on just chapter 23, basic provider first aid as a whole. I know we covered a lot of information in a short amount of time, but you know, when it comes down to those objectives, just remembering different things along the CPR, shock, bleeding control, just kind of what it entails in being a provider in emergency services, and then how emergency services is incorporated in the world and just in the multiple different ways. Also, keeping yourself safe, man. You guys want to make sure that you're taking those BSI precautions from those infection diseases, whether it's prophylactically or when it comes down to during the situation. You guys did an incredible job in the skills, both in the CPR section as well as the oxygen administration section. I went over your guys' test results with you. You guys did all incredible. Everybody passed. And then yeah, I thank you guys so much. I wish you guys have a great evening. And if there's anything else I can do for you, if you have any questions, comments, or concerns, feel free to come to me after class. And if there's any discrepancies, go ahead again and bring it up to me as well. If there's nothing else that I can do for you or anything, I'll go ahead and submit your guys' test results so you guys can get credit for taking this class, and you guys are good to go. Thank you.